Ensuring access to safe abortion in Nepal. In most high-income countries, we see safe abortions being conducted. However, in Nepal, which is a low and middle-income country, it is more common to see more unsafe abortions. These are conducted by people who lack skills and proper resources to do so. Due to this, more women are susceptible to complications such as pelvic sepsis, uterine perforation, and genital tract injuries. While 45% of abortions are unsafe, 97% happen in low and middle income countries, which is why we chose to discover more about experiences of women in Nepal who face greater risk of unsafe and complicated abortions.
In 2004, Nepal implemented a comprehensive safe abortion care program. Although medical abortions were available in around 64% of the country's districts in 2017, 58% of all abortions are done in secrecy. Because of challenges with traveling to places where safe abortions are accessible, women residing in mountainous regions are at higher risk of unsafe abortions. Moreover, due to stigma, women from lower socioeconomic backgrounds are more likely to obtain unsafe abortions. Additionally, approximately 45% of women are unaware of the legality of abortion. Because of these inequities, we decided to address unsafe abortions in Nepal. Over the past several decades, monumental gains have been made in securing women's rights to abortion, with nearly 50 countries liberalizing their abortion laws. Some of this reform have enabled women to access legal abortion only when there is a threat to her life or when pregnancy results from rape. But many changes have been truly transformative, overturning absolute bans on abortion in favor of women's reproductive autonomy. Here we have a global and regional comparison between Nepal, South Central Asia, and LMICs, which was also used to inform our country and disease of choice.
Abortion was legalized in Nepal by 2002, and the amount of unsafe abortions have decreased from 580 per 100,000 women in 1995 to 190 per 100,000 women in 2013. However, it still remains an issue due to the lack of knowledge, stigma, women autonomy costs, and lack of transportation women face, especially in rural areas.
To inform our response to the rate of unsafe abortions in Nepal, we must know about the structure of the country's health system. Nepal has a decentralized public health system and a mixed health service delivery system comprised of the public sector, private for-profit sector, and NGOs. The Ministry of Health serves rural underserved populations, while private providers, including NGOs and faith-based organizations, predominantly serve urban populations. Here are two figures that depict Nepal's public health system and the development of the country's community health program.
The major global goals surrounding abortion includes the Sustainable Development Goals. Specifically, abortion advances the goals of good health and well-being and gender equality. The policy recommendations that the Sustainable Development Goals gives is that abortion should be legal under broad grounds, such as legal at least in rape, life endangerment, which is what Nepal does now. In addition, it states that after this, countries should try to further reduce barriers to access and make the access to abortion follow WHO's latest guidance. So some relevant programs that have been studied include a study in Haiti that showed that text reminders and conversations with a digital expert was correlated with contraceptive uptake, along with an mHealth intervention being effective for sexual and reproductive health behavior change in low and middle income countries. And then when looking at programs specific to Nepal, we found that a mobile game app was an effective tool to reach rural Nepalis and teach them about reproductive health. So some background on the current issues we'd like to address in our mHealth intervention is that the big gaps to care were the distance to a healthcare facility, the fear of stigma from healthcare workers, especially for unmarried women, understaffing and underfunding, financial barriers of cost, as well as overall lack of education and discussion around sexual health in schools and in households.
So, based on what we've learned so far and the previous M Health interventions that occurred in different countries, as well as Nepal, we designed an M Health intervention in order to decrease a rate of unsafe abortion in Nepal called Svasthya, which means health in Nepali. So the goal of this mobile health intervention, as I said, is primarily to reduce the rates of unsafe abortion. However, it also works to provide a comprehensive resource for rural women who are the ones that are most at risk for undergoing unsafe abortion. And it works in two ways. It works as an informative as well as a communicative tool. So Swasthya's informative component does not require Wi-Fi, and it works as a living document. The reproductive health strategy that was mentioned earlier in terms of the existing policies addressing sexual and reproductive health will be used to guide the development of this document. And the resources included here include information for community health workers that live in the area, information about government abortion providers, and these resources would be updated every time the person is able to connect to Wi-Fi or use cellular data. If a person does not have a phone or a smartphone and they do have access to another device, it would be available online for non-app users. Another major component is that this would include resources for women that have experienced sexual assault or rape. And since we know that these women are more at risk for pursuing unsafe abortion, we wanted to address that here. In addition, there is a map feature which locates the nearest government abortion providers, and it updates when connected to Wi-Fi. But it does provide offline directions for women so that if they are able to access transportation, they are able to go to the health facility. The next component, well, on this slide, you can see some of the mock-ups of the informative component. In the second mock-up, there's a map feature. And in the third mock-up, you can see the mental health resources as well as government providers. The next part of the mobile health intervention is a communicative component. So this is designed for women that have both a smartphone and don't have a smartphone. So for those that do have a smartphone, they're able to use a live chat feature with a community healthcare worker. And women can chat directly with these people who can help provide resources for them if they are considering having an abortion or if they have other sexual or reproductive needs. The second option is for women that don't have a smartphone. They're able to chat with a robot. So for example, if they text a particular number, the system will be able to provide women with help based on their entries and based on a pre-existing bank. Women that can't read or write, especially acknowledging that many of the people that we're serving are in rural communities, lower socioeconomic backgrounds, or lower castes, they can call a community health worker and have them come to their home. And they could also have discreet delivery of family planning services. And once again, this works for women with and without a smartphone. And we see an example of the live chat feature on this slide. And this can be translated into any language that is present for the user.
So next we have ethics and equity. So confidentiality is key to our intervention. Because there is stigma in Nepal surrounding contraceptives and abortions, it is important that our intervention is private. So keeping this in mind, our app will be completely confidential and will not require users to enter personal information. Additionally, the app will include a list of mental health resources, as the experience of having an unplanned pregnancy can be very emotionally distressing. In regards to equity, our intervention is specifically targeted towards women in rural areas because typically they lack access to health resources. So to make our app accessible, it will be completely free, and most services on the app will be able to function offline. One unintended consequence to consider is when receiving stigma from other people if they discover the app on the woman's phone. To counteract this, we gave the app an unsuspecting, neutral name, and the app icon appears as something related to general health so that it would not create suspicion if someone else saw the app. How will we measure our success? So for immediate metrics, we can use data from our app, including number of app downloads, rates of contact to a community health worker, rates of follow-up, and other use of services. For long-term metrics, we can collect data on unsafe abortions and compare if the rate has decreased. Additionally, we can measure the rate of unwanted pregnancy and simply compare the data. If our intervention is successful, features on the app will be frequently used, and there will be a decrease in unsafe abortions in Nepal over the following years. For program sustainability, in 2017 to 2018, Nepal allocated 37 million for improving reproductive health care, and the government has increased funding towards family planning significantly in the past decade. This indicates that the government has recently become open to financing reproductive health programs, and we could apply for international grants if we cannot obtain federal funding. Additionally, once we get the money to design the app, operating costs to keep the app updated and running are relatively low, other than keeping the app technology up to date and fixing bugs, as well as periodically updating the resources. The app can sustain itself with little additional funding. And we have our contribution statements and references.